Today, we have with us Aimee Langan, Clinical Vice President, UHN, the largest hospital in Canada.
Almost the entirety of the patients that walk through our hospital doors have to spend some time in medical imaging.
So how do you keep the whole system running?
The dyadic model or relationship that sort of leads programs in hospitals is pairing a physician leader with an administrator like myself.
We need the best machines. We need the best technologists to acquire those images. And then we need the best radiologists to interpret those images. People often think that the hospitals are run by doctors and nurses. And the same is true for radiology departments as well, because anytime we think about radiology departments, all they think about is like a radiologist in the corner, sitting alone with his machine. And I'm not sure if you watched this old sitcom called Scrubs, in which there's this radiologist who's kind of wearing a robe coming in at night, and he says, "My machines, my machines." Just kind of really funny. But one day after joining here, I understood what a big machinery radiology is. Can you shed some light into the machinery of radiology and how it fits in the hospital?
For sure. Maybe I'll start with the latter part of the question first, how it fits in the hospital. When I try to describe the importance of radiology, frankly, to anyone who will listen, I always say the vast majority, if not almost the entirety of the patients that walk through our hospital doors have to spend some time in medical imaging, right? Whether it's for diagnosis, for treatment, for procedures, the care and the service that is provided in imaging is necessary for almost every single patient's journey, regardless of if it's an emergency patient, if it's a patient coming in for cardiac surgery. Almost every single one of them comes through medical imaging. So that speaks to maybe the latter part of your question in terms of the importance and the importance really of integrating medical imaging and radiology into all aspects of the hospital, integrating with care teams in different programs, integrating well with support services across the hospital, as you know, where patients are transported from whether it's their inpatient bed into imaging, from the emerge into imaging. And so there's a real sort of spider web or connection between imaging and all aspects of the hospital. The beginning of your question was the sort of the machinery of imaging, and maybe I'll start with the machines themselves. So we have really, as you well know, large, expensive pieces of equipment across the hospital that are really foundational to providing the care in medical imaging. Images, as you know, are acquired by regulated health professionals, our allied health team, and our medical radiation technologists and sonographers who really acquire the highest quality images possible so that the very subspecialized experts, such as yourselves, can actually take those images and interpret them, again, for the purpose of diagnosis and treatment of just about every single patient who walks through UHN.
That's perfect. So we need the best machines. We need the best technologists to acquire those images. And then we need the best radiologists to interpret those images. And this forms the basic structure of the crazy cobweb that is radiology, because, as you point out, we are one of the few specialties who touch almost everybody in the hospital. And in a weird way, it's our responsibility to make sure that the patient are transported to the right place from point A to point B, whether they're from emerge to surgery or wherever they are in their health journey. We kind of guide them along, make sure they kind of don't get way late and take them where they're meant to be. And I understand that now that brings so many people together, be it the people directly working with patients as well as a lot of the machinery around it, because it's not just the people who are acquiring the images or reading the images, it's also the entire system around it, because there's people for booking and receptionists and getting people ready and giving information. So I understand that you, as the vice president, you're in charge of everybody. And I also hear that there's this dyad model. Can you tell me more about the dyad model of leadership? in medical imaging.
Yeah, absolutely. So the dyadic model or relationship that sort of leads programs in hospitals is pairing a physician leader with an administrator like myself. And I have always said for my whole career that it is really an easy position for me to be in, to be in a partnership like this, because I'm not a clinician. So I could not do my job successfully without a physician or clinician partner. It is not my training, as I'd said to you at the beginning. It is not my background. I am a trained general administrator who happens to have a little bit of basic science background. So for me, the relationship with in this case, physician leader is necessary for me to be successful in leading programs like medical imaging. And I think that the value of the model it kind of lies in what I was just mentioning, in the sort of the complementary skill sets that a physician brings to the table and an administrator brings to the table. So in the case of my relationship with our program medical director for radiology at UHN, Dr. Heidi Schmidt, she obviously brings to the table a depth of expertise in the clinical world that I could never imagine to bring to the table. She understands the clinical care, the workflows, the physicians, the liaison with all of the other clinical programs. And on the flip side, what I bring to the table is a depth of expertise in running a program, in running operations, in thinking about, what are the strategic priorities of our program that are going to link more broadly to those of the organization, in thinking about how do we remove barriers for our team, make sure they have the right resources, help them solve problems, whether the removing barriers includes things like equipment and staff and data and collaboration with government. And so I think you really need both pieces of the puzzle in order to really successfully lead a program. And as I said, it's always been an easy position for me to be in because I couldn't do it alone. I don't bring that expertise to the table. I need Heidi by my side.
That's an interesting take, because I would say that, when I started as well, and a lot of other clinicians do feel the same way, because quite often in our careers, all we do is trained to learn clinical details, identify clinical details, and clinical stuff. Medicine is all we do. Mm-hmm. But one fine day, when we do that really well, we just thrust with leadership. The management side of it, the operations side of it, we have no idea as to how it's run. And quite a lot of times that's where I find that kind of leaders struggle, because they don't have a background in that.
Yeah.
So I would say that most of us would say that the clinical side is actually easy. It's just the management operational side that's difficult, which I think is great. Because this reminds me of something, because my sister is a software engineer. And in her first job she worked in, there was something called pair programming. They would pair two programmers together. They just have one keyboard and they type one code.
Oh, wow.
The idea was that they would bring in complementary skills and create one piece of product. That way, overall, the product is better. And studies have shown that there are less errors because they kind of complement each other. So in a way, what you're saying is exactly that, in which it's just two complementary pieces brought together beautifully to kind of run the system.
Yeah.
And sorry.
No, I was just going to say, what I might add, and that analogy made me think of it, is you need shared goals. So
Absolutely,
if you're pairing on the same keyboard with someone who's trying to go down this path and you're trying to go down this path, it probably ends up in disaster. And I think the same is true, could be true, with dyadic partnerships or models running clinical programs in a hospital. The great thing about healthcare is it's hard to find anyone in the system who doesn't have really similar goals, right? We're mostly all here to provide really excellent care to our patients, to their families, to provide a level of service at what is typically a very, very difficult time for these people. Mm-hmm. When you're at UHN, you add the layer of wanting to be innovative, wanting to do really cool new things that no one's done before, whether that's in research, in academia. And so if you have, and again, it seems like an easy position to fall into, but if you have shared goals with that partner, it makes working together that much easier.
Absolutely. So the sum of the parts become more than the actual sum of the individual parts themselves. Which is great. So the clinical side of it, yeah, we've had a discussion with Heidi as well as with a lot of other radiologists in this podcast before. But what are the challenges you face in the operational side of it? So some of the issues which are always faced with people in Canada, especially in Ontario, are the wait times. What are the main challenges in getting people scanned at the right time?
I think there are really clear sort of categories of those challenges. The first is probably the one that most people's minds go to initially, which is we just don't have the physical capacity to meet the demand that comes through our doors. So number of CT scanners, number of MR units, et cetera, you name it, in terms of the machinery. We in Ontario, in Canada, just do not have that physical capacity to meet the exponentially growing demand for medical imaging. You then pair that with the next category, which is you need money to run those pieces of equipment to manage your operations, to run operations. The hours that you sort of turn the scanner on and turn it off need to be funded. And so there's a kind of a bucket or a category around operating funding. And, in our public system, there's only so much funding for the entire system. And you can imagine how that's divvied up across different clinical areas and different priorities. And so, as stewards of taxpayers' dollars and trying to do the best that we can in a constrained system, we have to kind of stretch the funding that we have. But there are certainly constraints. It's not a run the machine as much as you want and and kind of move on from there. The next really important category, and we talked about this a little bit at the beginning, is the importance of the professionals that acquire the images. So our technologists. There's just not enough of them in the province. There's not enough of them in the country. The more we can do to encourage folks to go into this discipline, the better. The stronger we can grow the pipeline, the better positioned we will be to increase our capacity. I think the national vacancy rate for medical radiation technologists is around 12%.
The national vacancy rate is 12%.
I think that's true, yeah.
Wow.
Yeah.
So in a way, 12% of scans aren't being done just based on the human manpower needs.
If we had more equipment and funding to open operating hours, the bottleneck would be we don't have people to run.
People to run it, okay.
Yeah.
Wow.
Tell all your friends, get into the industry. Let's get more trained, regulated health professionals, more MRTs.
Absolutely, yeah. Like that. This is, and being an MRT is an absolutely amazing career opportunity because I work with so many of them and people love it. They work with people, they work with machines, and then they have a very good camaraderie between themselves. And it's always such a fun, pleasant place to work with. But yeah, I understand that the challenges are not only getting funding for the machines, but then funding for the construction of the said place. Because again, in Toronto, the real estate costs are very high. Construction costs are very high. So getting the machine into the hospital can cost even more than the machines themselves.
That's right.
And then these issues with the technologies then. So how do you keep the whole system running? And what do you think are the future ways in which we can further streamline and improve care delivery, given that we have all these constraints?
Yeah. I think part of the role of someone in my position and other leaders in the program is continued advocacy. So continuing to paint the picture for the government, for our funder, and to say, again, the demand curve is growing exponentially, and to continue to advocate for the critical role that imaging plays in the journey of every patient. I think then it's also again in my role looking at how can we make sure we are doing the very best with what we have? So continue to advocate for more, whether that's a greater pipeline of students to come into the MRT roles, whether that's for equipment, for funding of the equipment. But then it's also within the constraints of what we have, how do we do the very best with what we have? Are we as efficient as we can be? Are we as effective as we can be? Are we supporting our staff so that they want to stay and work in this environment? That's certainly a top priority for any leader, is making sure that the ecosystem that you are responsible for is as strong and thriving as possible. And then I think part of that entails the introduction of technology, new technologies, whether that's to future-proof the program or to bring in technologies that will support staff in doing the very best that they can with a really constrained system, with high demand, with high throughput. And I think that's quite frankly just the way the world is going, right? Moving more towards analytics and AI and advanced analytics. And so thinking about ways, and this is not my area of expertise necessarily, but thinking about ways that advanced analytics and AI can actually help maybe remove some of the barriers or remove some of those constraints that we may otherwise may not have been able to remove. So if there are ways to reduce the time it takes to do something, or take some of the routinized tasks away from our really critical human resources so they can focus on the more advanced, complex care, being with patients, collaborating with other clinicians, and again, taking away some of that maybe monotonous, routinized kind of administrative work, I think is all part and parcel of how do we keep this machine going as long as possible.
Absolutely. I think that there's always this concern that AI is going to take jobs away. However, I think what people kind of often fail to understand are the constraints which you mentioned, because we have financial constraints as well as manpower constraints. If AI is going to help us be efficient, that it's saving some time, or it's actually saving some people, they can be put in other places. And as you point out, there's a 12% vacancy rate. If it's able to do some part of that, then the rest of the technologists can efficiently manage that whole schedule. So, the thought about how a future radiology department would be is just so interesting. So do you have any future ideas, like down the line? What do you think a radiology department is going to look like? Do you think that we'd kind of have robots coming and doing all of this stuff?
I don't know if I'm not a creative enough thinker. I can't imagine a world where folks like you and your allied health partners and colleagues aren't still right there caring for patients. Maybe that's just my inability to think creatively. But, I think the future, again, looks, and maybe this is going to be a bit repetitive, but looks like making sure that you and your clinical colleagues are really focused on time with the patient, on the really complex clinical questions and care, and all of the other sort of what maybe feels like a burden right now, but the administrative tasks, the things that are really routine that don't need your or a human to intervene with can be done by computers.
Amazing. Like no more phone calls to us. We just take care of the scans. That's kind of all what we want anyways.
Exactly.
But are we doing anything right now? We always talk about AI as if it's in the future. But are we doing anything right now to kind of get it in the system right away? And are we seeing any benefits of AI right now?
I think there are a lot of pockets of trialing different AI tools in medical imaging right now, probably some that you can speak to even better than I can. In one case, we are looking at a scheduling system that will really help make that upfront process for the patient between receipt of referral from the referring provider to actually booking the study, make that as efficient as possible, as streamlined as possible, and most importantly, make sure that we are making the best use of our machines so that the schedule for patients on any given day on any given machine is as optimized as possible. And so using kind of AI and operations research technology to take some of the guesswork out of what I consider to be a Tetris game. How do I fit this patient into this spot and this patient into this spot? So that's something we're working on right now. I think the other thing that's really key for our program is making sure that we have a modernized platform in general for technology. Again, going back to my comment around future-proofing, so that we are prepared for and have a system that will allow us to kind of plug in new tools and technology as they become available.
That's interesting to hear, because as you point out, not every scan takes the same amount of time. So what you're trying to do is use AI to make sure that there's no kind of gaps between the scans. It's almost like, having like a bunch of pebbles in a box and then, just shaking it just so that they kind of fit in nicely there.
That's right.
So that definitely improves efficiency, and that also can help scan more patients. And secondly, given that we have constraints as to how many we can scan, the AI tool can then try and rearrange those patients so that the right patients can get scanned at the right time.
Exactly.
In an ideal world, we'd want everybody scanned yesterday.
Exactly.
But given that's not possible, I think this would be the best solution.
I think the other great thing about trialing this is there are constraints in any given day, right? This is how much time we have for contrast. This is, when the machine's on and off, or this is even constraints for certain sort of clinical pathways. This type of scan needs to be done within 28 days before a certain procedure that they also have booked potentially at UHN. So it's taking all of those factors and saying, instead of us, maybe guessing isn't the right word, but instead of trying our best to kind of mix and match all of those different constraints in the system, it's using the historical data to say kind of the best way to do this to optimize the use of your scanner looks like, A, B, or C. Okay,
that's perfect. So, Aimee, that was incredible insight into the machinery of radiology, how it fits, and the behind the scenes. Radiology itself, a lot of people consider it as behind the scenes, but to us, all what you do is actually the behind the scenes of us. So Thanks for shedding light on that. So in a final question, what advice or what can you tell to radiologists, clinicians who want to take up leadership in future? Because not everyone is going to have the opportunity to work in a dyad model, to have someone as amazing as you kind of sitting there and helping with all the operations of it. So what can you tell radiologists about your experience, where to start, and are there any nuggets of wisdom that you can give them?
Sure. I think I would start by saying maybe find a mentor, find a leader that that you respect or you look up to, that may be able to take you under your wing and show you around what it's like to be in their shoes. I think putting your hand up for a project at the hospital, for a government committee, for a committee at Ontario Health, for instance, will start to open your eyes to what it's like to be to be an administrator, to be a leader. And then I would say maybe start early in terms of thinking about your leadership, maybe not skills, but areas of expertise that you'd want to develop. Is it strategic planning? Is it in managing operations? Maybe see if you can find ways to either, again, support initiatives or work with a mentor to kind of develop in that skill set. In terms of nuggets, I think there's probably a couple that I would say. One is, once you get into a leadership position, figure out how to learn the ropes in terms of how and where to engage folks, whether it's for input, for advice, for endorsement, where decisions are made. That tends to be the tricky part in moving ideas forward, is have I taken it to the right people at the right time in the right way to help progress the idea that I want to implement. And sometimes, you can find yourselves running into roadblocks that maybe you could have otherwise avoided if you'd figured out the right path forward. And I think any leader or administrator at the organization can probably help you figure that out. That'd be a good one, I think, to think through is where are the right tables to bring this idea to get it moving?
Amazing. At the end of the day, hospitals are made of people, and knowing the right people can get you far in life.
True.
That's amazing. Thank you very much, Aimee. That was Aimee Langan, Clinical Vice President of UHN, and me, your host, Satish Krishna. See you on the next one.